Welcome back to Anatomiqa. In this session, we will be discussing on femoral triangle. The learning objectives of this session are: describe and demonstrate boundaries, floor, roof and contents of femoral triangle. Describe and demonstrate the femoral sheath. Describe and demonstrate the boundaries and contents of femoral canal. Explain the anatomical basis of femoral hernia and psoas abscess. Femoral triangle is a triangular depression below the inguinal ligament with the apex directed below and involves the upper 1/3 of the front of the thigh. It is bounded laterally by the medial border of sartorius, medially by the medial border of adductor longus. Base is formed by the inguinal ligament. Apex is formed by the meeting point of sartorius and the adductor longus and is continuous below with the adductor canal. The floor is gutter shaped and is formed from lateral to medial side by iliacus, tendon of psoas major, pectineus and adductor longus. Between the iliacus and the psoas major intervenes the trunk of femoral nerve. The gap between the psoas and pectineus transmits the medial circumflex femoral vessels. The profunda femoris vessels pass through the interval between the pectineus and adductor longus, and the roof is formed by the fascia lata. The contents of the femoral triangle are femoral artery and its branches, femoral vein and its tributaries, both enveloped by femoral sheath in the proximal 3 to 4 centimeters. Deep inguinal lymph nodes, a part of the lateral femoral cutaneous nerve, femoral nerve and its branches. Femoral branch of the genitofemoral nerve and fibrofatty tissue. Coming to the clinical anatomy of the apex of the femoral triangle, a sharp knife penetrating deeply through the apex, which is a rare case, involves beneath the fascia lata the following structures, which will be damaged from superficial to deep: medial femoral cutaneous nerve, femoral artery, femoral vein, adductor longus, profunda femoris vein and profunda femoris artery. In this dissected specimen, you can observe the three main contents from lateral to medial side very clearly: femoral nerve and its branches, femoral artery and the femoral vein. The femoral artery and the femoral vein are covered by a fascial sheath in the proximal part 3 to 4 centimeters beneath the inguinal ligament called as femoral sheath. You can observe the femoral nerve is outside the femoral sheath and is not included in it. The medialmost part of the sheath encloses a canal called the femoral canal. Let us now look at the femoral sheath in detail. Femoral sheath is a funnel-shaped fascial prolongation around the proximal part of femoral blood vessels. It is a broad part in the upper area and narrow in the lower part. About 3 to 4 centimeters below the inguinal ligament, it blends with the tunica adventitia of the femoral vessels. The function of the femoral sheath is it allows the femoral vessels to glide freely in and out beneath the inguinal ligament during the movements of the hip joint. The sheath is rudimentary in the newborn due to fetal position of flexion, but is prolonged below the inguinal ligament when the extension of thigh becomes frequent and habitual. The sheath is derived or formed from extraperitoneal connective tissue in which the external iliac vessels lie in the interval between the fascia transversalis and the fascia iliaca before they extend beneath the inguinal ligament as femoral vessels. As the external iliac vessels continue to extend below the inguinal ligament, forming the femoral vessels, they also take along with them the sheath around it. We are viewing the sagittal section from one side at the level of femoral artery. So, in the adult, the anterior wall of the sheath is formed by the fascia transversalis, present deep to abdominal muscles, and the posterior wall is formed by the fascia iliaca, which covers the iliac muscle. On the other hand, the femoral nerve is not incorporated within the sheath because it passes entirely beneath the fascia iliaca. The femoral sheath forms three subdivisions or three compartments. The lateral wall of sheath is almost vertical and the medial wall is oblique, slopes downwards and laterally. Two antero-posterior septa divide the sheath into three compartments: lateral, intermediate, and medial compartments. The lateral compartment contains femoral artery and femoral branch of genitofemoral nerve. The intermediate compartment contains femoral vein. The medial compartment, which is known as the femoral canal, contains lymph node of Cloquet or Rosenmuller. The relationship of saphenous opening to the femoral sheath. The falciform upper, lateral and lower margins of saphenous opening lie in front of the femoral sheath, whereas ill-defined medial margin of the opening passes behind the sheath. Therefore, the cribriform fascia covering the saphenous opening is present on the anteromedial surface of the femoral sheath. Structures piercing the femoral sheath. Laterally, femoral branch of genitofemoral nerve. Anteriorly, superficial epigastric, superficial external pudendal, which are branches of femoral artery, and medially, great saphenous vein, which opens into the femoral vein. Coming to the details of the femoral canal, it is very important from clinical point of view. It is conical and about 1.25 centimeters long. Its base is broad and directed above. It forms an upper opening called femoral ring. The apex is directed downwards. Femoral ring is bounded in front by the inguinal ligament, behind by the pectineus muscle and its covering fascia called pectineal fascia, medially by the base of the lacunar ligament and laterally by the femoral vein. The junction of the anterior and lateral walls of the ring is closely related to inferior epigastric vessels. I repeat, the femoral ring, which is the upper opening of the femoral canal, is closed by the femoral septum, which is formed by the condensation of the extraperitoneal connective tissue. The femoral septum is covered by the parietal peritoneum, which forms a depression on the septum. This depression is called the femoral fossa. The ring is wider in female because of the greater breadth of female pelvis and narrower diameter of femoral vessels. Hence, the femoral hernia bulging through the femoral ring is more common in females than in males. The femoral canal is potential or dead space containing the deep inguinal lymph node and some loose areolar tissue. As already discussed, the lymph node is called the lymph node of Cloquet or lymph node of Rosenmuller. The femoral septum is pierced by the lymph vessels connecting the deep inguinal lymph nodes with external iliac lymph nodes. The canal allows expansion of the femoral vein during increased venous return from the lower limbs. Coming to the clinical anatomy of the femoral canal. This picture is the sagittal section at the level of femoral canal. The femoral canal is an area of potential weakness in the abdominal wall through which abdominal contents may bulge out, forming femoral hernia. Direction of femoral hernia is important to know in what direction the femoral hernia occurs. This helps in the treatment during reduction of hernia. The femoral hernia, covered by a pouch of parietal peritoneum, bulges downward through the femoral ring into the femoral canal, then pushes forward through the saphenous opening and finally turns upwards around the upper falciform margin of saphenous opening towards the inguinal ligament. The probable reason why the hernia turns upwards and not downwards is maybe the Holden's line where the Scarpa's fascia from anterior abdominal wall is attached to the fascia lata. The reduction of hernia. The change of direction is to be followed in reverse order during manual reduction of the hernia with the thigh passively flexed to obtain sufficient relaxation. So the direction in which the hernia is reduced will be first push the hernia downwards, then backwards through the saphenous opening, and finally upwards through the femoral canal and ring into the abdominal cavity. Coverings of complete femoral hernia. As the hernia passes through femoral ring, femoral canal and saphenous opening, it takes along with it the following layers from within outwards: peritoneum of the hernial sac, femoral septum, anterior wall of femoral sheath, cribriform fascia, superficial fascia, and skin. In some cases, since the femoral ring is narrow, there are chances for hernias to be strangulated. In these cases, surgically, the narrow femoral ring must be enlarged. In surgical treatment of strangulated femoral hernia, the femoral ring is enlarged by incising the lacunar ligament on the medial side. Surgeons often prefer to cut the lacunar ligament, which is also called Gimbernat's ligament, during the release of a strangulated femoral hernia because it provides safe and effective access to the constricted hernial sac. This is the only structure which can be safely incised in majority of the cases compared to other boundaries. Because anteriorly, there is inguinal ligament which cannot be incised due to attachment of muscles and its relation to the inguinal canal. Laterally, there is femoral vein which is dangerous to damage. Posteriorly, there is pectineus muscle, pectineal ligament, and the bone which is difficult to access. Thus, cutting medially is the least risky approach, but important surgical caution should be taken care even in this approach. Sometimes an abnormal obturator artery may be present in relation to the lacunar ligament. In this case, cutting the lacunar ligament leads to hemorrhage. So to be on the safer side, The surgeon applies two hemostatic clamps on either side and the cut is made in between to avoid bleeding. Psoas abscess. It is a collection of pus in the iliopsoas muscle compartment and within the psoas muscle. The psoas muscle extends from the lumbar vertebrae in the abdominal cavity where it originates and extends to the thigh up to the femoral triangle where it is inserted to lesser trochanter of femur. The muscle is retroperitoneal, that is, it is present behind the peritoneum in the abdominal cavity and behind the femoral sheath in the femoral triangle. So, the infection can spread easily from abdominal cavity into the femoral triangle and cause a bulge as seen in this photograph. It can be classified into primary psoas abscess, which is caused by hematogenous or lymphatic spread of a pathogen, and secondary psoas abscess is resulting from contiguous spread from an adjacent infectious structure. The causes of psoas abscess may be lumbar tuberculosis, vertebral osteomyelitis, pyelonephritis, and through blood vessels supplying the muscle. Patients with Crohn's disease, diabetes, or immunocompromised states are at a higher risk of developing a psoas abscess. The symptoms of psoas abscess are fever, limp, and back pain. Thank you for watching till the end. If you have not yet subscribed to the channel, please do so. Thank you once again.